Hello, everybody. It's nice to have you here with our NoTube team. It's very nice that even members of the NoTube team are available. Not only my lovely wife, which you can see more or less next to me. She's staying now next to the Lake of Zurich, and I'm staying in Tel Aviv. So this is modern times at its best. We welcome you to our English webinar about our quite new program dealing with juvenile anorexia nervosa. Funnily enough, we have also received some questions regarding infants and eating disorders in infancy, and we'll be happy if time allows us to go also into this subject, which is one of our main subjects. Our history concerning anorexia nervosa is a long-lasting history. I remember when I entered the psychosomatic ward in '85, we had the first patient with suffering from anorexia nervosa, and I still remember our psychologist telling me that this is a life-endangering illness, and why should I deal with it? And my answer, I still also remember, I said to him, you know, we medical doctors are used to deal with life-threatening illnesses, and if we wouldn't, who would? And it was really a nice experience. He thought it would be too dangerous for him, so he left the subject. But Margaret and me and a couple of other people, like psychologists, psychotherapists, and all of our nurses, got more and more acquainted with this subject until we, in the end, like would say, like 20 years later, we were seen in the world as a specialized unit for eating disorders, which was at that time established as mainly first in Great Britain and afterwards also in the United States, and it spread it all over the world. What did we do? At that time, we had patients in an out and an inpatient setting. In the inpatient setting, we set really marks how much a child should gain in weight every other day. And it was at that time 100 grams per day. And this was quite strenuous for our children. We had also to give them nutrition using nasogastric tubes. We had a lot of discussions because in the beginning they were very anxious to gain weight because even if you are very slim, you feel obese. And some additional problems arose, like with minerals or essential fats or essential amino acids. So we had to go into a lot of these details, including the refeeding syndrome, which was at that time discovered coming from Great Britain. And we were very cautious to deal with it correctly. And then we made an intermission, one could say, from the year, let's say we made an intermission of 5 years not dealing with this disease. But then we found out, especially under the circumstances of the pandemic, that a lot of these young patients, mostly girls, are not treated adequately because they can't go to hospital due to the COVID restrictions. And on the other hand, they can't see their psychotherapist because for a long time this was not possible. So Margaret especially and me and some of our staff started to give possibilities of treatment using our online system, which we before had discovered and utilized mainly for infancy. And the new approach was that the affected patient herself could be in a daily contact with our team consisting of a psychologist, a nutritionist, which happens to be sometimes the same psychologist because she made additional training, and our oral therapists. So it's always 3 of them. And on the other hand, the parents may also have daily counseling. And with this model, we could see that the children thrive much easier than they did in an inpatient treatment. I still recall, before I hand over to Margaret, that I wrote an article citing an English researcher who built up 5 different locations of specialized treatment for anorexia nervosa, only to find out before he retired that his treatment options hadn't been better than local community treatment. So they made outlines of what you must look at and how you can treat anorexia nervosa is not dependent on the kind of location you build up, on the kind of treatment team. It is only necessary that it contains a therapist, mainly a psychotherapist, an eating therapist, a medical doctor, and to make it possible for the patient and the parents to be well heard and to find a red line which they can follow in order to get healthy again. And the good news Margaret will now deliver to you is that surprisingly enough, it works sometimes even better than a hospital in or outpatient treatment. Thank you very much. This was the first impulse. And now perhaps, Margaret, you want to go on.
Yes, I'd like to take over exactly where you stopped. We were discussing and thinking very much about this nearly astonishing discovery that the online treatment model seemed to us, after the first dozen of patients, to be superior. And we thought, how can this be? How can the last 70, 80 years of inpatient residential treatment be suddenly followed up or taken over by the modern technology? And I would like to try and explain this on 3 levels. And I would like to distinguish between the level of efficacy for the patient herself, the level of subjective support for the parents, and the model of taking the local medical team, it can be a pediatrician or a family doctor, into the team to do the local necessary weight supervision. Now, in this really horrible illness, something very crucial happens in the minds of our patients, which is distinctly different from practically all other diseases. Because normally in medicine, if you have a problem, you go to a doctor, he seems trustworthy, you do what he says, and you want to get better. Now, in anorexia, it's very rarely the case. In anorexia, these children are kept for weeks and months at home. Everybody tries their best, but things get worse. And then they're more or less dragged to the hospital and told to trust somebody who, from their perspective, doesn't look very trustworthy. And nobody seems to understand their truth, because anorexia nervosa patients are convinced that the physics of their metabolism and the physics of their body are per se different from everybody else. It can go so far that they even think that the energy of the sun and the fresh air is enough to keep them alive, and that they, for special reasons, don't need calories. So we are dealing with a patient who basically, from the mindset of the illness affecting the brain, doesn't see any reason why to change the situation, and is basically very untrustful. He's the girls are kind of dragged with their parents, and they of course don't want to make more sorrow and anxiety to their parents, but basically they don't want to change their situation. Now, our online model starts, and we're very specific about this, with our own contact channel with the patient, in which the parents have no entry. So it's a kind of individual secret, individualized and tailored to each patient therapy approach, where we start not with the so-called problem. We start How do you feel? What's been going on? What are your hobbies? What are the things you enjoy in life? Actually, how are you sustaining yourself? What are the conflicts you're having with your mom? What are the opinion of your friends? So we can start on a much more general level, knowing that this patient is being once a week seen by the local pediatrician or family doctor, and knowing that this patient is at home under the surveillance and the love and the care of the parents who, of course, wouldn't risk their daughter getting into a more critical situation. So the patients at the beginning are kind of surprised that we don't talk about force, we don't talk about you must. We take about a full week to get to know the patient and to try and establish a trustworthy relationship, whose goal is to manufacture an individually tailored therapy treatment plan for this specific girl. So every single patient kind of is entangled in making her own treatment plan. And if a girl says 100 grams a day, I can't manage that, we'll try to discuss, and we might end up with 70 grams a day, or whatever we can solution we can find in a respectful and integrating the patient's ideas manner. Now, the parents on a second level need completely a different approach. They need support. They need understanding for their utterly exhausted state of mind. These parents are in a kind of prolonged anorexia-caused burnout. They have been for months and months trying to do their best to kind of set back their own wishes, how they want to cook, how they like to cook, the kind of food which is served on the table, in respect and in recognition of the illness of their child, not to upset their daughter. They sometimes have stopped cooking and only eat cold things because the young lady has said, I can't stand the smells. And to get the parents out of this servant role of being the kind of helpless accompanist of the tyrant having the illness is one of the very, very important first things the parents need. We tell them, get upset if you're upset, scream if you want to scream. Start telling your child that you can't stand this situation anymore, or maybe it's better to just leave the house, stop cooking. So there are a whole lot of things which might even seem paradox, but the parents are also guided and supervised on a kind of basically parent empowering, but made also how should I say, they produce their own way of what do we change first, and in which listing do we want to set the priorities, what is upsetting mom or upsetting dad the most, and where do we have to change at the beginning. And to be able to accompany both parties, which are needing very different things, we often have to we have to really divide the care the one needs from the care the other needs, and the parents don't hear from us what we are writing and communicating with their daughter unless the daughter herself or the son wants to communicate with the parents. So if the daughter says, listen, the therapist told me this and this, she said I may do this and this, then of course the daughter can share this with her parents. But the parents are not going to hear from us what we are discussing with their daughter. And the third reason why I am, in the meantime, convinced that this online model is it's the treatment of our new 21st century. It's just the other treatments have a different history. And 70 years ago, after the war in the 60s, when this illness really started exploding in Europe, residential treatment was more or less the only model we had. And now we can get local doctors to feel heavily supported and glad to have a partner in which their role as a local doctor is very specifically defined. And they are very, very happy and relieved that the kind of psychology of supporting this illness is taking over by us, that also the specific nutritional levels are calculated and defined by us. And what they have to do is, at the beginning of treatment, examine the young lady and assess whether there are any medical examinations or lab counts necessary. And from that point on, if the findings are normal, as mostly in anorexia, unless we are dealing with young ladies with a BMI less than 12, we start with weighing the child once a week in the praxis of the colleague, who should be living as near and close by as possible. And there are two options: to either weigh the young lady blind, that means that she doesn't need to know how the weight is changing, or she wants to know how the weight is changing. This, I think, was more or less the basics of our plan. This very intensive daily contact with both the children and the young ladies and the parents goes on for exactly 3 months, after which we have a quite good estimation of which weight has to still be reached for the young lady to be reintegrated in her social system. And after the first 3 weeks, this is the Weight Doc basic program, they can switch to a monthly support program called Aftercare. And that can go on for either patient or parents or both for as long as they basically wish and need. Do we already have questions? Yes, I can see the first question coming in. I think it's, how does the online communication work? Is it on a platform, or are you doing video calls? Thank you very much. Very good question. We are using a data protected communication platform on a daily level, which is what we call dysynchronized communication. It can happen that parents ask for a Zoom, and then we will try and do up to 1 or 2 Zooms in the first phase with the parents. It is sometimes also necessary at the beginning to kind of sort things out and to get a real good impression of where we are starting from. But as treatment moves on, we are just writing on the ticket system about 2 to 3 times a day. The patients we have had in the program up to now are 10, 11, 12, till up to 17. But basically, the dynamics of anorexia nervosa can happen. The conflict of autonomy versus control, desire for more control of the outer world, can happen. It can also happen in young adults. It can even start in young adults. My very first patient started getting ill at the age of 29. That was nearly 50 years ago. So basically, the discovery that by not eating, you can gain power and in a pathological way increase your self-confidence and position in the world can happen at any age. But the most of our patients are early onset anorexia, so 10 to about 17, which would be the classical age. Are there more questions from the audience?
Any questions? Where do you see them?
In the chat.
In the chat, I have no new questions. I just looked into the chat, but there is no questions. It's only the introduction from Cassie. But there are no more questions.
We yesterday had a very interesting question right at the beginning, trying to ask us to explain the separation anxiety or the level of anxiety. How can one understand that these mothers are in such an absolute critical mindset, really believing that if they don't force feed their daughter, the child will die? And I think this was a very interesting question, because it also is more or less the same maternal mindset as we are dealing with when we're treating infantile anorexia. And even if we are dealing with other non-medically caused eating disorders in infancy or early childhood or after choking episodes, it is a discrepancy between how the patient feels, who mostly feels either well or not so ill, and the impression of the outside world, which is just alarmed to an extent that they have the feeling that this is a life-threatening situation. Now,
I just want to add, I was asked whether we treat also boys. It's normally worldwide a relationship 9-1 in favor of girls. So we had a few boys to treat in hospital as inpatients and outpatients. Boys present mostly also with what you can call a sport anorexia, where they move a lot and lose weight also because they use more calories than they take in. Sometimes even this is at the beginning a desired situation because they want to lose weight in order to run faster or move quicker. And then it gets out of hand. So boys sometimes need a different approach, which deals with the ability to move and to move fast and to be able to compete with their peers. But yes, we treated boys and we are still happy to treat them. And there was another question whether our approach is quick enough. And I want to come back to that, what Margaret said. The physical state of a child is also to be assessed by the local doctor, because we personally, in most cases, don't see the child hands-on. We don't see her in either city we are in. Sometimes we meet them not only in Graz, but also in other cities. But if we have no possibility to make a medical assessment and to look and differentiate how the child is working, if it's weak, there are also have been guidelines, mainly from Great Britain, what you should check, whether the child is still able to make a somersault or to bend down to the floor 10 times and come up again, or if the child is able to crawl out of the bed, or how often the child faints. All these cornerstones of functioning we would assess if we meet the child. Otherwise, we advise parents to go with the child to the local general practitioner. We also hand them in these cornerstones which have to be reached, and then this has to be decided by the local doctor.
We got a very interesting question from Mrs. Birgit, whose daughter hasn't been eating anything since 2 weeks. She started this 5 weeks ago, and she has lost as much as, and this is really very much, 11 kilos in the last 5 weeks. Now, this is dramatic. The first thing which I would suggest is that we do have to be sure that this child suffers from anorexia nervosa. There are quite a lot of differential examinations which I would need and we would ask for before we take this child into treatment. And the main question would be, is the diagnosis of anorexia has been confirmed by outruling any possible other medical cause? Because 11 kilos in 5 weeks is absolutely dramatically much. Now, our program can start today or tomorrow. So we are definitely fast enough. We can also start when the child is still in hospital by supporting the parents and by giving the parents advice how to deal with the situation their daughter is in. Now, usually when a child loses 11 kilos in such a short time, I suppose that she is now getting a tube. This was also yesterday a question. Do we treat anorexia nervosa if the young lady or man is at the moment currently tube fed? The answer is, of course. We're absolutely specialized in tubes, and it would depend on the nutritional details and on the growth details to see whether the tube feeds need to be continued from a medical point, which we would probably say would be necessary up to a BMI of about 13, maybe 14. But above that, we would strongly advise first to invest 1 or 2 weeks into tube weaning or getting the child home, even with the tube. Any young lady can tube feed herself, or the parents can take over. And then we would have to look at the individual growth data to really make a plan, because the weight at onset is crucial. The weight, the minimal weight which has been reached is crucial, and the target one is aiming for is crucial. So we have to look at this before we can give a general answer. We would have to discuss with Frau Kinzel in a so-called assessment, which can be done today. It's called on our website. You can get a free evaluation, or you can dive into direct assessment, and then you're in the medical team. Upload 3 videos. If you have anything just showing the child, fill in the questionnaire, and also give us the medical reports which exist on the child. So in this case, I would kindly ask Mrs. Kinzel to contact us directly so that we can really look at the situation of her daughter on a personal level.
I just want to straighten out a misunderstanding. Also, anorexia nervosa is a medical condition, because you name medical conditions which are somatic conditions. We are doing medicine no matter whether it's organically focused or non-organically, or both is an origin. And Mrs. Kinzel wrote that they make blood controls. We strongly advise you not to rely too much on blood controls, because normally they don't show nothing, especially if it is not leukemia, but it's perhaps anorexia nervosa, and it's diagnosed by the AKH in Vienna, which I suppose then blood counts don't give you additional information. The main thing is that the weight loss is stopped. This is now the next question, especially for the health of your daughter. What made your daughter stop would be our first question. Was she joking? Had she was there an event? Did she see a movie where she felt that the animals are tortured? What made her stop? Margaret, do you still want to go also in the questions concerning infants? Because we have some of those, especially, let's see, from Egypt. We have one from Egypt.
Yes, it would be lovely. I can't read them right now, but...
Why not? Multitasking. Yes.
Frau Kinzel just answered.
Okay.
She said it started by children mobbing her daughter in school and telling her daughter apparently that she was fat and not pretty anymore.
This is a very good start. We can understand the daughter. We would now, if you go into our assessment, we would assess also the biological data like length and weight and so forth.
Yeah, but she was not fat, because 47 kilos with 163 is for sure not fat. And now she lost 11 kilos, so she's only 35, 36, which is clearly a severe malnutrition. Yeah. So, yes.
So this looks to us a very promising and very new, not long-lasting diseases.
Have a better prognosis.
Very good prognosis. Okay. Lovely.
Yeah.
Now we go into the questions which I mentioned before. We have a question, for example, from Egypt. We are asked, let's see, opala, I just had it. No, it lost. What are the protocols? Our protocols are very tailored to each patient. We don't have general protocols. Margaret, who is more into numbers, Mrs. Sadar has more feelings of protocols, but we don't really follow guidelines because it had been shown that the guidelines are not based on scientific knowledge. We ourselves, like Dr. Marguerite and others, and we ourselves made scientific research which shows quite clearly that you have to tailor intake and the protocol of gaining, of eating to every child. And so I would like still to go to the questions reaching us from the United States. There was one question about obviously a son, an infant who doesn't start to eat solid foods. And there was a second question about learning to eat. We are quite familiar with both problems in infancy as well. Mrs. Samantha Almodova and Julia Krishansovska. We can say that especially these children on the verge of going to kindergarten, they have, especially if they are male, they can develop a disease or a specificity which you call picky eater. And there had been a webinar in our series, which was made by Dr. Marinchek and Eva Kershichnik. And I think it's still available, so it would be lovely if you would see this. I think it's available on YouTube. Most probably, Melanie Butch will write it to you now in the chat, where you can see how we deal with this problem, which is also true for Judy Dauphiné from Canada, who has more or less the same problem of a picky eater.
I would like to add that on our website called just notube.com, which is very easy, there's a special section called explore.notube.com. And there we have the opportunity of free evaluations, or you just sign in for assessment, and then we are communicating with you on an individual level. And this has no waiting time. And the free evaluation, as it says, is free. It lasts about 20 minutes. And the assessment costs, I think, 180 euro. But it's a thorough evaluation of two professionals looking through also the medical reports which we get, and it's well worth it. The reason why we do this assessment is that we don't want to accept children for treatment and risk their parents paying a lot of money if we basically feel that we are not the right team for this problem, or if we feel that the situation cannot be changed in a responsible manner. Then if the child, for instance, has a very severe swallow disorder, that's one of the main reasons why not to accept a child. And we also haven't discussed yet the two main options of our team are, as we've been talking all the time now about the online approach, we also have a beautiful, unique and worldwide first eating school located in Graz. And in this eating school, we conduct monthly 2-week courses, which children with anorexia nervosa, children with picky eating, and children with tubes can visit. So for any kind of, I would say even acute and chronic eating disorder, where one feels one stuck, the eating school is an excellent alternative if your child is able to travel and if your child, from an immunological point of view, is able to be integrated in a mixed children's group of 8 or 9 or 10 children. Ronnie, do you want to go into the costs and cost coverage of insurance?
No.
Okay, I'll very quick answer that question.
No.
Okay.
No. Here, Miriam Felix from Mexico says she's interested in Graz model, and I'm very happy to tell you that, first of all, you can see it on our webpage, how our model works. There's also a lot of scientific and non-scientific answers to your question. And we are in good mood because the book which explains the Graz model even more in depth is going to arrive this fall on the market. So feel free to use all these possibilities and to look more into our model. It's very easy. The main thing about our model is that it's child-led. It's not us who know better. It's not the parents who know better, but it's a child whom we support to find its way. And we try to make parents empowerment so they can believe in and rely on the child. Margaret, I don't know whether we should go into the cost question.
Yes,
because all costs are shown on our webpage.
The question was more about insurance coverage. And there we can't give you a general answer because it depends extremely much from which country you are asking these questions.
What kind of insurance plan you have?
There are countries like Switzerland where I just currently, where parents are used to paying every treatment themselves, and after the treatment they hand in the bill to their medical insurance, and in 95% of the cases, if it's a kind of a classical situation and not a two alternative treatment plan, the bill will be paid afterwards. In other countries, you have to kind of convince the German-speaking countries, you have to more or less convince the insurance partner that your case is a special case and that this child unfortunately lacked the opportunity of receiving adequate treatment in the medical systems which were accessible to the child, and convince them that there is effective treatment and options for help for the child. And in the most cases in the German-speaking countries, this will be refused in the first instance, but will be confirmed positively in the second instance. So one has to have a little bit of patience, and you receive, after the child has been through the assessment process, you receive from NoTube a kind of listing of all the parts of the treatment which interest insurance companies, listing how many sessions of medical supervision, how many sessions of psychological treatment, how many sessions of sensory integration, and so on are offered. And when the insurances see that this looks like a trustworthy treatment plan, in most cases the parents can rely on a coverage. Do we have another question? I think this question also depends in many countries nowadays where the medical system and the health system are quite different. Parents tell us that they go for modern ways of collecting money, which would be like crowdfunding, finding a specific company supporting children with rare diseases or medically fragile children. Children with specific diagnosis often have a kind of a carrier company where the parents are supported. And our experience has been that a sum between 5,000 and 10,000 euro is not so difficult as parents fear to collect. So if you have a set of 50 good friends and you're really desperate and you really convince them that this is the chance in the life of this young lady or young child to get an effective treatment, you will often be very surprised how quickly each of your friends will be prepared to give 50 or 100 euros, and then the whole thing becomes very much easier manageable. How long does the program for anorexia last? Thank you for this good question. The basic first program lasts 3 months from the point on when we start. And this will depend whether the child is still in hospital or already at home. But basically, as soon as we start the intensive phase, from then on, it's 3 full months, with the option of discussing with the parents how and what we recommend to continue if the child in these 3 months is not out of the critical phase yet. Our average weight gain recommendation is 500 grams per week, which is 70 grams per day. So if the weight loss is something like 10 kilos, which has to be gained, then of course the 3 months will not be quite enough to gain this, but then we would advise them to take the aftercare program after maybe a phase of trying herself. But basically the program will last until parents and patient are confident that they can now manage on their own.
Very good. I wouldn't like to conclude not saying that this disease offers a lot of challenges, and it's not an even way. The positivity of my lovely wife, which I like very much, tells you only that things go well, but they don't do all the time. There's a lot of problems on the way, not if it's so a short notice disease like it was with this girl losing 11 kilos, but we have chronic developments which don't go that easy, and also a high involvement of parents. We have seen families who were very interested in food all their life, like being vegetarian because they want to protect the environment or look after the animals. And now the child does the same like the parents, it only exaggerates. And then the interaction between us and the family has to be very respectful for the different points of view concerning nutrition. We, being medical doctors, think nutrition is mainly to sustain your health and your power. But other people think there's a lot of more to it. Some people even think sentences, which are mostly in German, you are what you eat. We don't believe in that because we know a lot about digestion and inner metabolism. So we have to be quite respectful with the different approaches running in families and running in children, and also those things which are now taught to children in respect of environment and so forth. So sometimes the road is not even, sometimes it's bumpy, sometimes it's containing up and downs, and this is what we are here for.
Wonderful. Do I get to know what you discuss with my daughter? Yeah, that's a very good question. This is about intimacy and the right of young people to be protected from the intrusion, even if it's meant with nothing but love of their parents. And if parents fear that to lose their child because of not eating enough, they become very, very, very distrustful and very intrusive. All the more, it is crucial that we make clear to the parents that they are not going to get a communication what we are discussing with their daughter. We will tell them that they may ask their daughter herself what she's discussing with us, but we have to protect the child's sphere of intimacy to be able to establish a trustful relationship to the team. And anorexia nervosa, as you all know, is not only about losing weight and gaining weight and having the kind of perfect body, it's mainly about making the transition from being a dependent child to becoming a person with an own mind, with own wishes, with own goals in life, and gaining some independence. And this is a theme which in the classical family, if this exists, literature tells us that this kind of family does exist. In the so-called classical anorexia family, the relationships are entangled and are enmeshed, and the parents, in the best of intention, intrude in their daughter's need of autonomy and independence. And this topic has to be very much respected from the first moment on in the contact with both the parents and their child. So the parents are told that they will not get to know what we are discussing with their daughter, and they should please ask their daughter, and if she doesn't want to share it with them, this must be respected.
Additional question whether we use medication. Online we don't. Sometimes we recommend it, but it must be prescribed by the local doctor. We don't give online prescriptions until now. Now in Austria it's allowed, but we don't have only Austrian clients. And I think it's a quite tricky thing to give an online medication to a patient you have never seen in real. So I'm not sure, perhaps it might happen, but until now it didn't.
Maybe closing, to get back to our initial theme of the anorexia nervosa, I think that we would like to very much encourage you just to take a free evaluation, discuss it with us. What you can discuss whether the case of your daughter is a case at all, whether it's necessary to do something. This was very frequently in the outpatient clinic of our hospital, the case that parents would come, if we were lucky, even months before the weight situation got really critical, and supporting the parents before it got critical is a very good idea. So don't hesitate to just inform yourself and get yourself stronger in getting out of the role of being the servant of a young lady with an addiction problem to becoming a responsible and autonomy-giving parent of a growing up young person.
Other question was now whether we work with bulimia nervosa. And our online program can do that very well. When I started, like let's say in the 80s, to deal with that, it was called the untreatable disease. This is not true anymore, but still it's a much more complicated situation, especially when vomiting comes more than a few times daily, and it destructs the teeth, and it destructs the everyday life. And it's a very frequent disease, and the treatment outcomes, as far as we know from literature, are not really promising. I wanted to ask you, Margaret, do we have any numbers?
Numbers on what?
On treatment outcomes of bulimia nervosa.
No. We don't have any, because it's the problem is that the age group is not our main focus. We have very rare contacts of parents of people over the age of 15. And since bulimia rarely starts under 15, it is one of the rare contacts.
It's like boys for us.
Yeah.
Anorexia
is much, much, much more frequent. And the interesting thing, since
not in young adults. in young adults, especially
Around.
in Singapore, New York, San Francisco, bulimia would be more frequent.
Exactly. But since the pandemic started, the age of contacting us in the young people with anorexia has been 10 to 12, has been extremely, surprisingly young, in an age where the symptoms can be very dramatic, but the prognosis basically is a better one.
Yeah.
Is promising.
That's true.
What is the role of the local doctor? Yes, would you like to say that, Ronnie, or shall I say that?
Oh, no, it's okay. You go on.
Well, the role of the doctor is, I think I covered that before. It's very important at the onset of treatment to be sure that we are treating a person in a medical stable state. Anorexia can, especially if it lasts for months and months, lead to very critical disbalances of the electrolytes in the metabolism, and basic big blood count with vitamin count and hormone counts is the kind of onset blood workup which we would recommend. And it's also good if the young lady was inspected by her local doctor, just to make sure that we're not overseeing another illness. The local doctors mostly are very relieved to get a clear task. And we ask them kindly whether they will be prepared to do more or less, nothing but the role of being the medical supervisor of the situation, to make sure that the weight is gradually increasing, and to contact us if the weight is not increasing. Because these young girls sometimes, without a bad intention, they cheat, they drink a lot of water, and so we have to make sure that there's an outside family checker to just make sure that the child is in a at least stable medical condition. And yesterday we were asked whether there's a minimal BMI, and we would say above 12 we can start immediately, and BMI under 12 we would definitely first contact the local doctor and make sure that the young lady is stable in what my husband referred before to as the marzipan criteria. That means that her energy level and activity level has to be good enough to move freely without difficulties in her own home.
Okay, marzipan is an abbreviation for a number of, no, it's not an abbreviation. It's a word condensed of a few words. Yeah. It's not an abbreviation. Okay, medical assessment of, what is the R for? Of, okay, for endangered children. We were asked whether we treat patients over 18. Our eldest patient was a lady in her early 19s after a tongue operation who felt she couldn't swallow anymore. And she was the mother of a director of operas we were friends with, and we treated her. So then our main objective is not so much medically, but more the way of psychotherapists who know a lot about nutrition and essential needs. But as we are both psychotherapists, we have, regarding psychotherapy, no age limitation. So it can be, our patient can be already being in a retirement home.
Yeah.
Doesn't matter. And I think a lot of patients in retirement homes would benefit from that, because it's very sad that they stop eating sometimes there because of a couple of factors, which...
Also after a classical stroke, even if a classical stroke was the reason why they were put onto a tube, mostly they get PEG tubes very quickly, there is a chance in quite many of these patients to regain oral eating when they survive the stroke situation. Yeah. So age is no criteria to refuse a patient.
Yeah. Lovely. So you see, refusing is not our main objective.
Okay, I think we will
close.
end with inviting you to look at our lovely website, which I must say for the anorexia patients, you have to go and type in weight doc program for anorexia, otherwise you will not find it. And just contact us and we will be happy to make the next step and discuss it with you. I would like to thank you very, very much for your attention, for your very good questions, and we'll be happy to meet some of you in the next few weeks. Thank you very much.
Yes, thank also to the team which was present from all over the world, especially also Marion Russell, who stays in United States, who would be the first person to contact within the United States. Thank you very much also from my side. Bye-bye.